what's been your take on other high efficacy medications like B-cell depleting therapies such as Ocrelizumab? I know there was some data presented at ACTRIMS looking at the open label extension and 6-year data on relapse rate and disability progression.
Yeah, there was a good poster there by Dr. Hauser, basically termed long-term reduction of relapse rate and confirmed disability progression after 6 years of Ocrelizumab treatment in patients with relapsing MS. As we know that there were 2 extremely important studies done for Ocrelizumab, OPERA-1 and OPERA-2, and that was a double-blind placebo period, basically the 3, and then there was a 3-year follow-up studies for a total of 6 years of treatment. And this is what Dr. Hauser is presenting. So basically, they took the patients who were previously randomized to Ocrelizumab, and they continued them on Ocrelizumab, or they took the patients that were previously randomized to interferon beta 1A and switched them to Ocrelizumab. And then they looked at the adjustable annualized relapse rate, time to exposure of the 24-week confirmed disability progression, and change in the adjusted mean EDSS score. And basically the results showed, a favorable outcome. And, their conclusions were that after 6 years of follow-up, the proportions of patients patients had lower relapse rates and improved disability outcome with Ocrelizumab. And also there was a benefit showed on the patients who were on Ocrelizumab for 6 years versus the ones who were switched at 3 years. So I was basically saying there I will kind of directly quote them here, that switching from interferon to Ocrelizumab after 2 years at the start of the open label extension period was associated with reduction in acute relapse rate. And then both the Ocrelizumab portion of the trial and the interferon Ocrelizumab patients maintained their reduction in acute relapse rate through the 4-year follow-up of this open label period. So to me, the significance of this data is that here we have a medication that, as I spoke of earlier, which is more of a high efficacy medication, and showing that it clearly worked better than a lower efficacy but higher safety medication such as interferon. And this is always heartening to me because I'm on the induction side. Now I'm going to reverse course here a little bit on you, Matt, and that is, in my anecdotal experience, and again, I'm going to say that again, this is with my anecdotal experience, I personally have not found Ocrelizumab to be as effective as I have seen it in the trials, especially in my primary progressive patients, and which they did receive a indication for that. And when I look back at that study, I'd be curious about your opinion on this also, Dr. Baker. When I looked back at the initial primary progressive study, some of those patients had, T1 GAD enhancing lesions. Some of those patients had relapses. So I really felt like a significant portion of the patients that they were calling primary progressive actually would fall into what we would now call active secondary progressive multiple sclerosis. And I think this is what led to the statistical significant difference in the Ocrelizumab patients versus a placebo in the primary progressive. What are your thoughts about that?
Yeah, I tend to agree with that. I think that the data in the primary progressive trial was driven greatly by those patients that had inflammatory disease. In the real world setting in my practice, the patient that I have with primary progressive MS has been followed for 10, 15, 20 years now. And now there's a medicine that's approved for primary progressive MS, and they maybe have a very low burden of disease in the brain and significant burden of disease in the spinal cord, and not, there's no evidence of active and enhancing lesions. So I think the expectation out of the medication is to prevent or delay further disability progression. So I'm dealing with an older patient population with longer duration disease with less active MRI finding. And so, yeah, I would tend to agree with that. But, like I think any other therapy, early identification, early initiation of effective therapy, which is what the 6-year data showed, getting someone on effective therapy early on, at least in the relapsing forms, is critical. Probably the same for primary progressive MS. I tend to be more of a lumper. I think MS is MS is MS, and it just, I think the progressive nature of it might be driven by more spinal cord involvement or other host factors and genetic factors.